So, on your way to become a great surgeon, this is the first pit stop. We're learning about surgical nutrition and metabolism, and I am Dr. Sananur Rahman. This is the second section of this presentation in which we'll talk about the nutritional assessment. This section will be dealing with the nutritional assessment of a patient who comes to you for an elective or an emergency procedure. We'll see what are the various formats of the nutritional assessment, what is their sensitivity and specificity, what formats are used commonly and what are not used commonly, what are the pros and cons of these formats, and then we'll talk about the nutritional indices and other methods for nutritional assessment. I hope you're excited about this lecture. So let's get into it and see what happens. So first of all, what is the need for nutritional assessment? Now, a patient has come to you and is asking for an elective surgical procedure. What should be done? Obviously, you'll talk to the patient, you'll ask for the history, you'll see whether the patient requires the surgery or not. Again, it is an elective procedure, so it is not, it's the patient's choice. It is not necessary per se, but the patient needs it, the patient wants it. And if you're not giving the patient that, the patient will go to someone else and get it. But that is not the point. That is not what we're discussing at this point in time. What we are discussing is the need for nutritional assessment. So while you're questioning your patient for an elective procedure, you'll ask for the you'll assess the nutritional status of the patient. That is because a healthy individual would easily, with most likely less complications, go through the surgical procedure and come out and be healthy again in a shorter span of time. As compared to a patient who's nutritionally challenged, it would be difficult to maintain that patient. During surgery, the anesthetic complications would be there, the surgical complications would be there, and then afterwards, the resuscitation of such a patient is also difficult. So having an idea of the nutritional status of the patient gives you something to work with. It gives you an idea that how you'll proceed once the patient has gone through surgery, how you'll resuscitate the patient, how you'll manage the patient till such time that the patient goes home, and even after that if he requires nutritional correction. So what can be the complications of malnutrition? So we can have infections like a wound infection, intra-abdominal infection. We can have sepsis. In sepsis, the infection has spread throughout the body. The bacteria has entered the bloodstream. We can have pneumonia or gastrointestinal infections. We can have urinary tract infections and catheter-related infections. So this is the category of infections. Then we can have non-infections like they can be post-operative bleeding due to a slippage of the suture or something. Then we can have an anastomotic leak. So you made an anastomosis between two objects, and then there's leakage from that. Then we can have impaired wound healing. We can have gastric obstruction or perforation, very serious post-op complication. Then we can have cardiac, renal, or respiratory dysfunction. Okay, renal dysfunction is very common in post-surgical patients. You have given a great variety of drugs during anesthesia. You have given a great variety of drugs during the surgery. Hence, these drugs can act on the kidney and cause somewhat renal dysfunction in these patients. And the patient can also go into multi-organ failure. So all these causes, be them infectious or the non-infectious causes, can lead to a prolonged recovery period. There's increased need for nursing, there's increased medical cost, and there's prolonged hospital stay. So all of the infectious causes and even the non-infectious causes are somehow complications of malnutrition. That is because the body does not build up on the immunity. The body is not strong enough to withhold such a stress, to undergo such a stress. So for that reason, the body either enters into infectious complications or non-infectious complications, or an amalgam of the two, and these cause prolonged recovery periods and prolonged recovery stays. All of this is due to is somehow related to malnutrition. Now, what is subjective global assessment? So, in subjective global assessment, we try to assess the needs of the patients. So, how do we do that? We do that by physical examination. You examine the patient physically, and you tend to find out about the health and the nutritional status of the patient. Now, when you are performing the physical examination, you should always look for any muscle wasting, unilateral or bilateral, the generalized body weight, the BMI, any history of nutritional deficiencies, any nutritional problems in the past, any other conditions that might be of importance, if the patient is suffering from an allergy or any other chronic diseases that might cause nutritional deficiencies. Then the anthropometric measurements, the height, the weight, these measurements help in establishing the general. They give you a general idea of the populace, that is, what are the general anthropometric measurements in the area in this population, so that you can compare them to your individual. These include the weight, the height, and the weight loss history. We can have dietary questionnaires. These dietary questionnaires are self-administered and help in determining the dietary history of the patient. Then we can have portion size analysis. We can ask about the portion size of the patient's meals, and then we can analyze them, and we can see which patient takes a bigger portion or a lesser portion, and how frequent is the patient eating, and how is the patient's health in general. Now we should also ask about about the pertinent past medical history. So this is very important because the patient might have a surgical procedure in the past. The patient might have a disease in the past that might have affected the nutritional status of the body. Now, and then upon these bases, the patients are classified on the basis of past medical history into Class A, Class B, and Class C. So in Class A, we have individuals with no evidence of malnutrition. In Class B, we have individuals with moderate or intermediate malnutrition. And in Class C, we have patients with definitive malnutrition. So moving on, let's talk about the anthropometric measurements. So they provide information regarding the lean body mass. So the percentage of lean body mass in the generalized population as well as your patient. Then the total fat stores of the patient, and the overall nutritional health. So the three components that these anthropometric measurements give an idea about. These include the lean body mass, the total fat stores, and overall nutritional health. So there are various techniques that are being used to measure these anthropometric measurements. The most commonly used technique is the BMI. So BMI is the body mass index. The body mass index is measured as height in kilograms divided by weight, weight in kilograms divided by height in meter square. The result of which is interpreted as either underweight or malnourished, then we have normal, then we have overweight, then we have obese and very obese. So another method is C-ray absorptiometry. It is a less commonly used method, not practiced very often. Now, what are the various nutritional indices? So, nutritional indices, they provide a mean of the risk which stratifies and objectively compares the individuals as well as to guide nutritional support. So, these nutritional indices are there for comparison and guidance. They compare them, they compare the patient to the general population of the area, and then they also guide you to make a proper dietary or a nutritional plan so that your patient can recover and gain his health and proper nutrition. So the nutritional indices include the BMI, which is the body mass index. Then we have PNI, which is prognostic nutritional index. Then we have NRI, which is nutritional risk index. And then we have CHI, which is creatinine height index. So these are the these are the equations with the help of which you can Maya or Maya these I'll read these equations. These equations have to be memorized. However, their use is limited and is not very common. So first of all, we have PNI or prognostic nutritional index. Equals 158. It's a constant. Then we subtract albumin multiplied to 16.6. Then we subtract the tricep skin fold thickness. You measure the skin fold thickness around the tricep, multiply it with 0.78 and subtract it from albumin and 158. Then you subtract 0.2 multiplied by transferrin, and then subtract 5.8 with delayed cutaneous hypersensitivity. So a very complicated equation, requires a lot of testing and not commonly used. Again, we have the NRI, which is nutritional risk index, equals 1.59 times albumin plus 41.7, which is multiplied by actual weight in kg divided by actual weight. This is the nutritional risk index. And finally, we have the creatinine height index, which is calculated as 24-hour urine creatinine excretion, which is divided by the predicted creatinine excretion based on the height. So these are three equations, slightly chunky, somewhat difficult, not commonly used. But these nutritional indices help you to plan a corrective pathway for your patient and also help you to compare them to the people of the area. The comparison is important because sometimes demographically the people who are thin, who are lean, who are small, so you get an idea of the general populace as well. Now, a serum protein level. This is a protein electrophoresis diagram in which this is the curve of albumin, then alpha 1, alpha 2, beta 1, beta 2, and gamma globulins. This generally is this is how an electrophoresis diagram shows. So serum proteins are actually the serum protein level or the serum they are serum markers. They help you, they give you an idea of the nutritional status of the body. These include the albumin, the prealbumin, the transferrin, the retinol binding protein. Now, the albumin is commonly measured. The albumin is the protein that is circulating in the body. It is a pretty abundant protein. However, it is an acute phase reactant which is secreted in the acute phase, and there's a complex relationship of albumin in the body. However, the decreased albumin generally shows a decreased bad or a malnutrition, or a patient undergoing malnutrition. Chronic malnutrition usually has a decreased albumin, prealbumin, transferrin. The protein markers are usually combined with C-reactive protein. C-reactive protein is usually high. The protein markers are usually low. This picture usually depicts an acute infection. In chronic conditions, the protein markers are usually depressed, and you can get an idea, or generalized idea, of how and what is going on in the body. So this is a table that summarizes the role of these proteins. First of all, we have albumin. So albumin, the reference range is 3 to 5 grams per deciliter. The half-life is 14 to 20 days. It is elevated in dehydration. So since in dehydration there's decrease in the body fluid, so I won't be going into much of the details of these conditions, because the details of these conditions would take a lot of time. So I'll just read them out. They are the dehydration, marasmus, blood transfusions, and exogenous albumin administration. Now the albumin is decreased in aggressive resuscitation, ascites, so again liver is not producing it, eclampsia, liver failure, inflammatory states, nephrotic syndrome, protein losing states, the burns, trauma, post-operative states, and so on and so forth. Now we have prealbumin. The reference range for prealbumin is 18 to 45. The half-life is 2 to 3 days, so it can be repeated earlier as compared to albumin, and can be used as an acute phase reactant, and also to monitor the effect of nutritional therapy. It is elevated in end-stage renal disease, corticosteroid use, and oral contraception. It is usually decreased in post-operative states, hepatitis, liver failure, inflammatory states, dialysis, hyperthyroidism, pregnancy, and severe hyperglycemia. Then we have retinol binding protein. It is about 4 to 6 milligram per deciliter in the body. The half-life is 12 hours. It is again elevated in end-stage renal disease, diabetes, obesity, vitamin A overdose, corticosteroid use, and oral contraceptives. Now it is decreased in post-operative states, hepatitis, liver failure, inflammatory states, and vitamin A deficiency. Now finally we have transferrin. Transferrin is about 200 to 250 milligram per deciliter. The half-life is about 8 to 10 days. It is elevated in iron deficiency, the dehydration, pregnancy, oral contraceptives, estrogen, chronic anemia, hepatitis, liver failure, hypoxia, and end-stage renal failure. It is decreased in pernicious anemia, anemia of chronic disease, folate deficiency anemia, aggressive resuscitation, chronic infectious states, iron overload, acute catabolic states, uremia, nephrotic syndrome, liver failure, Kwashiorkor, old age, zinc deficiency, corticosteroids, and cancer. So this table gives you an idea that how these proteins come into play and what are their roles in nutritional status assessment. You do not need to memorize this table, but a basic understanding of the table will give you an idea as to how and when these tests are being ordered. So nitrogen balance. So nitrogen is produced whenever proteins are being used as fuels in the body. So proteins are always being used because there are nitrogenous bases in DNA as well as their new proteins forming all the time in the body. So these nitrogenous bases, they are produced, the nitrogenous waste are secreted through the body through urine via kidney. And the nitrogen balance is a balance between the consumption and the excretion of nitrogen in the body. Nitrogen balance can be negative or positive. A value between -2 and +2 usually is the normal range of the nitrogen balance. So let's see. It's a marker for overall nutritional status of the body. It indicates whether protein intake and catabolism are in balance. Alright, so it assesses the progress in patients on nutritional support, obviously, -2 to +2 grams per day is the nitrogen equilibrium. You have to maintain it within that. Nitrogen balance gram per day can be calculated by protein intake, which is divided by 6.25 minus total urinary nitrogen plus 2. And then we have another equation in which the nitrogen balance equals protein intake, which is divided by 6.25 minus urea nitrogen plus 2 plus 3. These plus 2 and plus 3 figures, these are the consonants that are added or due to the insensible nitrogen loss in sweat and through the skin. So moving on, we have indirect calorimetry. So in indirect calorimetry, we measure the calories of the body indirectly. It is used for bedbound patients. It measures the carbon dioxide which is secreted from the body. The carbon dioxide is secreted as the carbon dioxide is actually a byproduct of the fuel that is used to produce energy in the body. So this carbon dioxide, when it's excreted from the body, is measured and gives an idea of the calories being used in the body. So it measures the resting energy expenditure. It calculates the heat produced through the measurement of oxygen which is consumed and the carbon dioxide which is exhaled. So patients must have a fraction of inspired oxygen, that is about 60% or less. So it, with the help of that, it measures the calories that are being used in the body. We have metabolic energy expenditure. So it is estimated on the basis of all the metabolic activity that is occurring in the fat-free body mass. These equations are specific for men and women and can be adjusted according to your daily bodily requirements. That is the amount of activity that is being done daily. These equations can be adjusted for that, and with the help of that, you can maintain your weight at that particular value. So these equations are known as the Harris-Benedict equation. These are separate for men and women. So for men, we have BMR equals the basal metabolic rate equals 88.362, which is added to weight in kgs multiplied by 13.397, which is added to height in centimeters, which is multiplied with 4.799, and which is subtracted from now from all this you have to subtract the age in years, which is multiplied to 5.677. So a complicated equation, not used commonly, but a very important equation. For women, the BMR equals 447.5, which is added to weight in kilograms 9.2 into 9.247, which is added to 3.098 times height in centimeter. Now subtract from all of this, you have to subtract 4.330 times age in years. Now, if there is little to no exercise of a patient, the daily calories needed is equal to BMR into 1.2. Now, if there is light exercise, that is about 1 to 3 days per week. Now, the daily calories needed are BMR multiplied by 1.375. Now, if there's moderate exercise of about 3 to 5 days per week, we have daily calories needed increase to BMR into 1.5 with heavy exercise, which is done 6 to 8 days per week. The daily calories needed equals BMR into 1.752. And with a very heavy exercise, that is twice per day, extra heavy workouts, the daily calories needed equals the BMR is equal to 1.9. So these equations are important in helping maintain your weight and can be used as such. So the other parameters of nutritional assessment, these include the total lymphocyte count, the CHI. CHI was the creatinine height index, the ideal body weight, the weight loss over time, the skin antigen testing. So there are various conditions in which these measurements or these parameters are being used. These parameters have their own specific interpretations and can be used in the maintenance and in the progression of a patient towards towards a healthy nutrition. So this was all about this section. We went through the section in pretty detail. I hope you understood it. For further such sections, keep watching sqadia.com.